So we're going to have a series of cases that we're going to discuss today. The first one is post-traumatic deformity. Dr. Vander Voort.
All right, thank you. My name's Wyatt. I just finished up residency at UC Davis, and I'm headed to Cleveland Clinic for fellowship in a couple weeks. So this is a case of a 74-year-old male presented to the emergency department in September of 2022 after falling down the stairs. He was diagnosed with a C7 fracture, who ultimately was lost to follow-up and then returned with a progressive deformity that we'll talk about. He has a past medical history of hypertension, diabetes, and AAA. No relevant surgical history as it pertains to the cervical spine. He's a current everyday smoker with 150-pack year history. On his exam on presentation, he was neurologically intact. Here's some select slices of his injury CT. Most notably, I think you can appreciate a fracture through the C7 vertebral body, which extends into the bilateral pedicles and lamina, traversing the facet joints. So these are upright x-rays that were obtained in the emergency department. There was maybe a little bit overzealous junior resident who sent this out with a caller and planned for close outpatient follow-up, which unfortunately never occurred. And about 8 months later, the patient returned to clinic with these imaging findings. So you can see progressive kyphotic deformity at C7T1. And here's a CT scan as well. And then this was an MRI that was actually obtained in the interim at an outside hospital, demonstrating, again, that kyphotic deformity with cord compression at that level. So in summary, again, a 74-year-old male, prior C7 fracture, progressive fixed kyphotic cervical spine deformity, neck pain, inability to maintain a horizontal gaze, and some gait disturbance concerning for progressive myelopathy, with findings of stenosis at that level and fixed kyphosis. So I guess is discussion time now about
Yeah,
treatment?
absolutely. So,
okay.
Very interesting case. Can you go back to the original injury CT? And can you comment on any factors that you think might have contributed to this guy's eventual problem?
I think there's probably disruption of the posterior tension band. I think on the first slice there, maybe a spinous process fracture at C6 with some gapping there, sort of like a flexion distraction type injury. And then obviously a fracture line extending through the bilateral pedicles. So I think it was more severe of an injury than was originally appreciated in the emergency department.
Yeah, and the other thing, if you look, he's auto-fused in many areas.
Sure.
And so he's got kind of a longer lever arm than somebody who may not be auto-fused, and a lot more stress on the area of injury. What would you have done originally? I guess you weren't the junior resident seeing him.
Thankfully not. I think I probably would have recommended a posterior fusion, probably a level above and below at a minimum, but given the long lever arm from the fusion construct, I'd be more aggressive in terms of the number of levels I'd select. So maybe something like C3 or C4 to T2.
Okay. Let's see. Let me call on somebody here. Mike, if this was you, what would you do at this point?
I think, timing-wise, like initially if this guy comes in, we're talking about this point.
the original
Yeah.
injury.
I mean, timing-wise, you're thinking probably the fastest way to treat this is to address it posteriorly. I would probably go a little bit longer on the construct than just one above and one below, and try to get some more rigid fixation. You see this kind of auto fusion that it's hard to tell where it stops, but at least it's up around the 4 area. So I might go up to like 5, and then it definitely get into like the T1 pedicles for sure to get some really robust fixation down there.
Would anybody treat this non-operatively initially?
You don't have a preoperative, you don't have an MRI at this point.
No.
So I feel like that would be critical, right? Because you see how much edema there is anteriorly, posteriorly, et cetera. I mean, I would think if there isn't a lot of disruption anteriorly, you in theory could put this in the collar and watch it every week if you wanted to, but it would be hard to believe that he doesn't have an ALM. But the fracture, it's 50% of the facet. I think it looks unilateral, so the predictability of it falling apart is, 30, 40%.
It's also going to be hard to follow conservatively. Just so you see that in the X-ray when you come, or the X-ray
right,
shortly
exactly.
afterwards, it's really hard to see.
Because you can't.
So what are you
shoulders.
following?
Make sure our head doesn't fall.
Yeah.
Okay. And I think the other factor, of course, is sort of the reliability of the person. If you got a guy like, you, I might say, okay, we'll watch you really carefully. But if somebody's not reliable, then you kind of have to over-treat them in a certain sense. Okay. Want to keep going?
Sure. So at this point, we elected to perform a two-stage procedure. Started from the front with a C6-7 corpectomy and a C5 to T1 ACDF, and then 2 days later went back for C2 to T4 fusion with a C5 to 7 laminectomy. So these are just some fluoroscopy images intraoperatively. We had ENT assistance with the exposure, and so there's that. And here are his pre and post-op sagittal images.
Did you put him in traction?
15 pounds in tongs.
Prior to
In the
surgery?
operating room or before?
Not before, just in the OR.
Rick, would you have put him in traction
I would
beforehand?
have brought him in the night before, just overnight. Because if you can reduce this, your operation, especially your anterior operation,
Sure.
way easier. Way easier. And I would probably just have done an interbody. I would have only done one level anterior and then flipped him over.
I think, in CT, what do the facets look like? There has to be a reason it didn't reduce. Maybe it's stuck in the front, but, I mean, I agree with the traction. If the facets aren't ankylosed in that position, and even if they were, I might do a 540 to avoid fusing the whole spine. I mean, it's a big operation.
So I'm curious, what was the reason for the corpectomy?
The primary reason, at least that we had discussed, is just that he felt it was more of a fixed deformity, and again, just to restore that anterior column support and get that correction, he felt like a corpectomy was necessary.
For neurologic decompression or for?
I think it just more so like to sort of unhinge that C7 T1 deformity. It felt like it was too stiff at the time to restore the disc space, I think.
Did it reduce at all under anesthesia?
Not significantly, no. After we put the patient to sleep, we put the tongs on and took some lateral fluoro shots, and it wasn't significantly improved in terms of the kyphotic deformity reduction.
And so you went anteriorly, and when you did the corpectomy, did it then reduce?
Mm-hmm.
You didn't have to reduce it from the back. It was fully reduced
Correct.
once you did the corpectomy?
Uh-huh.
Yeah, when I look at that, I kind of echo similar comments that I think Rick and Vince made, that maybe this could, I mean, the outcome looks great, but I wonder if you could have done either a single level discectomy with something posteriorly, and maybe not have fused all those levels, but a lot of those levels are fused. I think they're auto-fused on their own.
Mm-hmm.
I don't think we have the benefit of seeing all the images. Any comments from any other faculty?
See, the other advantage of traction is if the anterior approach in someone who has truly a fixed deformity, it's really hard. I mean, you're operating in a hole. I mean, it is really difficult. And if you can just even improve that a little bit preoperatively,
Sure.
that changes everything.
What did you put for bone graft when he's smoking 3 packs a day?
So primarily autograft from the corpectomy,
From the front.
from the front.
Posterior?
BMP.
BMP in the front? you
back.
said? In the back. Let's see. All right. How's he doing post-op?
He never followed up, so
So he's doing great.
yeah. So
Well, that's a great case. We have probably about another minute or two for discussion. Alpesh, what kind of bone graft do you use for these kind of cases?
So, I mean, anteriorly, you should have pretty good bone, right, from the corpectomy to utilize. Posteriorly, I've stopped using iliac crest. I'm usually using a synthetic, product of some kind. But I'm getting probably more diligent about grafting the facet joints. So level by level by level, burring out the facets and really making sure you're packing the facets before I instrument. I think before I used to just do posterolateral like onlay and it seemed to do okay, but I just like the idea of packing the grafts a little bit more, the facet joints a little bit more, but I'm using like a off-the-shelf synthetic. But the anterior, if you're going to do a multi-level corpectomy here, you've got lots of bone. You may even have enough bone left over that you can keep it for the backside, right? So, would you do something different, John? Have you moved away from iliac crest, or you?
No, I don't use iliac crest almost at all, other than I use it for C1-2 fusions. But otherwise, no, I don't use iliac crest. You use BMP posteriorly?
almost every case, yeah, at UC Davis at least.
Zoe?
Another option for autograft posteriorly is just take some of the spinous process.
Sure.
It's easy and it's available.
All right, great case.
Thanks.
We'll move on.